مساء الخير على الجميع. Good afternoon for everybody. Thank you for coming on a Saturday afternoon. I know it's at family time. We're going to discuss today coronary ectasia and coronary arterial aneurysm. And this topic has really no guidelines. It all depends on many things on the angiogram to decide what to do for these patients. So I'm going to try to discuss as much as I can, and we're going to have a lot of discussion and open talk with the doctors we have here. So I'm going to start with a case that presented to Jordan University Hospital 2 years ago. This is a 56-year-old male patient. He's a smoker. He does have a family history of coronary heart disease. He has a history of Meniere's disease, no history of diabetes, no history of hypertension, who presented to the ER with a 3 days history of chest pain. His chest pain is associated with shortness of breath, sweating, vomiting, bilateral arm numbness, typical anginal chest pain. And this was his ECG. As we can see on the ECG, he does have a subtle ST elevation in lead 3 and lead AVF with a Q wave already. His anterior leads look okay. And he has 3-day history, so we took him to the cath lab. And this was his first shot in the cath lab.
His enzymes were positive?
Enzymes are positive, and eventually his enzymes peaked at 49,000. We have high sensitivity troponin, which is equivalent to about 50 troponin to the normal one, so about 49,000 peaked. And as we can see here, he does have... The question on this patient, if you recall to that patient, see him in the cath lab, is what to do next. You're dealing with a severe coronary ectasia. Clearly there is a big thrombus in that vessel, and there is reduced blood flow distally, and the vessel is at minimum 8 to 10 millimeter in size. And we all know that in the cath lab we don't have more than 4 millimeter size stents. We have special stents we can push up to 6 millimeters, but we don't have anything that can go up to 10 millimeter stents. What anticoagulation protocol we need to use for these patients, what procedure to do for them, what are the medication we're going to send him home on, and what's his long-term prognosis. We're going to try to discuss these, and before that we're going to overview the topic. Coronary ectasia is defined as segmental or diffuse dilatation of the coronary arteries up to 1.5-fold of the normal segment. This is from the CAS registry, where we've had about 20,000 patients, and this is the definition they use for that. The question always comes up, what do we call normal in some patients? Because some of these patients, they have very diffuse vessels, very ectatic from A to Z, and you don't know where to go to call normal in these patients, and that's a challenging these patients. On the other hand, coronary artery aneurysm is localized dilatation of the coronary arteries to at least 2-fold increase of the normal adjacent segment, which is much easier to make a diagnosis because it's very focused, localized, and you do see normal segments next to it, and you can do that. We we can distinguish aneurysm from ectasia. It has a sharper beginning and end point, and it involves a shorter part of the coronary arteries. Our patient that I presented has coronary ectasia, is very clear, but this is another patient here where we can see this patient has localized dilatation of the coronary arteries, and this is a challenging patient to deal with. Definitely there is associated coronary artery disease and atherosclerosis in these patients with localized dilatation there. We can discuss what would be the best option for this patient, and I don't think we will agree at the end, but whether we can do PCI with embolization for the aneurysm, which would be one option, or send him to the surgeons would be the other option. If I were to work on him PCI, I would request to have somebody from the Interventional Radiology department who work on embolization for brain aneurysms, because that would be a way to do it. But I think the easy way to do for this patient is to send him for cabbage. What do you think, Rad? Huh?
Me?
Yes.
Okay. I think the best here option for these patients, thanks for asking. I think if it was up to me to, I would go rather than make the story complicated with the covered stent and with stents and embolization. If he has a good story with that degree of aneurysm, send him for surgery.
Okay. Anybody will do intervention on this guy? رائد. كله رائدات ما شاء الله.
I think doing an intervention here, as you mentioned, with the stent and you coil it, the neck, it is a small neck for the aneurysm, so it is possible. But really to get the wire out of this aneurysm, it will keep, the tip of the wire will keep just swimming there in the aneurysm. It's very difficult to go distally, it's not easy one. But anyhow, I agree, I think surgery, I would send the patient to surgery before they get.
I think the best for this guy is probably the surgery because these aneurysms coming on a bifurcation angles, very difficult to work. You're going to probably lose some of these important vessels on the side. But this is an example of a challenging case here. So the coronary ectasia has been classified into type 1, 2, 3, and 4. And this classification mainly done for research purposes. And so when you do research on ectasia, we're doing a study right now at JAMA on ectasia, and you do this classification to classify your patients. Most of our patients that we see, they are mostly type 1 ectasia, like for this patient here, for example, where we do see ectatic left main, LAD, left circumflex, ramus intermedius, RCA. This is a diffuse ectasia involving all his blood vessels, and this patient is a type 1 coronary ectasia, and this is really associated with coronary heart disease, as we can see in the ostial LAD. We have some in the ramus before and after, some of the ostial LAD. This is a very common association. Prevalence. Coronary ectasia is seen in anywhere between 1.2% up to 4.9% in coronary angiograms. It depends on the population where you do your coronary angiogram. I'm going to show more data on that in the next two slides. Most commonly involves a single blood vessel in 75% of the cases. Mostly that's the RCA in about 70% of the patients, followed by the LAD, and then followed out by the circ. And as we said, the RCA is the most commonly involved. Left main coronary ectasia is very rare. It's less than 1 in 1,000 of the population. Risk factors usually involve it affects men more than women in the ratio 3 to 1. Hypertension is very common in these patients, and smoking appears to be more common in coronary ectasia than coronary artery disease. And although it's not an issue for us here, cocaine use has been found to be an independent predictor of ectasia irrespective of smoking history. I'm not sure whether we have data on COT the same way or not. I don't have any experience with Yemeni patients, how common is ectasia in Yemeni patients, whether it has something to do with this or not. In our patient that we presented early on, he is a male and he has a smoking history, so he has 2 risk factors for the coronary ectasia we have seen. On the other hand, diabetes has a lower incidence of coronary ectasia than other risk factors. And that may be due to downregulation of the matrix metalloproteinase enzyme in diabetic patients. And usually diabetic patients have negative remodeling rather than positive remodeling. Negative remodeling means the vessels shrinks down. That's why I have diabetic vessels. They're very small vessels. They have diffuse small vessels, so they don't really grow up. So usually diabetics have less risk of having ectasia than smoking men with hypertension. This is a study, this is a table which has all the patients' studies that reported on ectasia. And this is from the first one was the CAST trial from like the 80s, about 20,000 patients they have in that study. Up to 4.9% they had ectasia. And as we can see, anywhere between 1.2% up to 6%. This is 1,000 patients from Saudi Arabia, they reported on that. As we can see in these patients, most of them, anywhere between 59% up to 85%, they have coexistence of coronary heart disease. So this is, as some people think ectasia is a form of presentation for atherosclerosis. Associated things, dyslipidemia up to 63%, hypertension is very common, between 45 to 64%. On the other hand, diabetes is not that much, 27%, 16%, 31%. The only study from Saudi Arabia reported a higher incidence of diabetes. But again, I'm not saying diabetes does not involve ectasia, but it is not a risk factor for that. Maybe the associated coronary heart disease that's caused by diabetes can lead to the coronary ectasia. Etiology for coronary ectasia. The most common etiology that lead to ectasia is 50% or more of the cases they have atherosclerosis, coronary heart disease. Other ones involving, like, for example, Kawasaki disease. We're going to present a case, and I think Mahmoud has another one also with that. It's childhood vasculitis can lead to that. Syphilis, we don't have syphilis anymore in the world, but it's reportedly can cause this. Connective tissue disease, Marfan syndrome. Other forms of arthritis, vasculitis, less than 10%. And there are people with congenital form of this disease. Underlying history of dilated aortic root with bicuspid aortic valve. They have a connective tissue problem that can be associated with coronary ectasia and coronary artery aneurysm. Okay, this is a 42-year-old patient presented with a large aneurysm in the RCA as well as in the LAD and the circ. And as we can see, the one in the LAD and the circ is also associated with associated with underlying coronary heart disease. How do we know this is Kawasaki disease or not? We need to take history from the family. Do they have a childhood illness of high fever illness, skin rash, joint disease or not? And then you associate that with Kawasaki disease. I don't know, Dr. Aouni, is there other ways to...
As you mentioned, the clinical, we add conjunctivitis, specific rash, fever more than 5 days, and acute markers, CRP. The platelets comes very up, reaching to more than 1 million, high CRP, high ESR. All together, we add them and we reach to...
conclusion. But for us in adults, we see them 20 years later on with disease, and then we depend on the family, the memory of the family to say, oh, he had this illness. But usually this illness does not pass without recognition. People will recognize that they have a bad illness. Usually makes them go to bedridden for a week or so, and then they will remember that. Clinical presentation of coronary ectasia and aneurysm. Many of the ectasias are asymptomatic and found accidentally during doing cardiac catheterization for some other reason, for evaluation, or they can present with a form of ischemia, either due to angina or myocardial infarction. Angina happens because of associated coronary heart disease that comes in with the ectasia, or because of the slow blood flow that can reduce the TIMI flow, leading to ischemia and demand ischemia. On the other hand, they can have a myocardial infarction, like our patient that presented early on, that can happen because of plaque rupture in the associated disease, or because of a thrombus formation due to the sluggish flow, or sometimes down embolization, distal embolization from that thrombus formation in the ectatic vessel. There has been also reports about increased risk of thrombosis in these patients, not only because of dilated vessels and ectasia, but there's also reports about imbalance between coagulation and fibrinolytic pathways in these patients, increasing the risk of thrombosis, and this is, we need to keep that in mind as a targeted way to treat these patients. Now we need to treat their increased risk of thrombosis. There are also reports of increased platelet activity in these patients, and I have the reference in the next slide. And as we all know, in these patients, we have a lower rate of successful reperfusion because of the slow flow, the ectatic vessels, that we're not able to completely do thrombectomy in these patients. Because of all these reasons, they have a higher mortality rate than patients with have only coronary heart disease with ACS without having any ectasia. Diagnosis. The main modality of diagnosis up to this point still we're using coronary angiography. However, cardiac MRI, MRA, and coronary CT angiogram is picking up, and we're making more diagnoses with these. The MRA is non-invasive. We can do a Doppler study for the flow on these blood vessels, and we can diagnose that. has no radiation, and it's an excellent tool for follow-up. Because if you have somebody who's 30 years old who has a significant ectasia or has an aneurysm and you do follow-up for them, if you're going to do an annual CT scan, you need to calculate the dose of radiation for these patients. Cardiac MRA does not involve any radiation, so that's an advantage for follow-up if you have that tool available. On the other hand, coronary CTA is still non-invasive. There are improved protocols nowadays, and we have less radiation. We have more control on the dose of radiation for these patients, and can be an excellent tool for follow-up diagnosis and follow-up on these patients. Okay. When we do coronary angiography in these patients, we look for signs of ectasia, and the stain we see in these patients because of the sluggish flow. We need not to be fooled that that's a dissection, because sometimes, many times, we look at this stain and we confuse it with a dissection. So that would be another thing we need to differentiate when we look at these angiograms and make sure we don't have any dissection in these vessels. And there's always the delayed antegrade flow, the reduced hemiflow in these patients. IVES is an excellent tool, especially if we're planning to do an intervention in these people, to get the luminal size of these vessels, as we said, because these vessels are huge and we need to know the size of these vessels. If the vessel is too big, we're not going to put a small stent, because if we put a small stent in a big vessel, that is a nidus for thrombosis and no flow in these patients. So an IVES can help us determine the size of the vessel, identify wall changes, differentiate true from false lumen, especially for aneurysms, and we can evaluate for plaque evaluation these patients before and after the ectatic segments and see the associated coronary artery disease. Because if we define CAD with ectasia, as we said, the prognosis is not as good as without having coronary artery disease. Management. Unfortunately, we have no guidelines on the management of coronary ectasia. We have to individualize treatment plan for each patient depending on their ectasia size, thrombus burden, associated symptoms, other vessels involved or not involved, available resources, and it's usually a very challenging patients to deal with, as many of the people in the room dealt with patients with this condition, especially when they present with acute presentation. However, in general, the goal for treatment for these patients is to minimize thrombus formation, prevent thrombus formation, and minimize thrombus formation, and that will involve somehow some form of antiplatelet and maybe anticoagulation. We need to stabilize plaques for the associated coronary artery disease. As we said, most of these people have associated coronary artery disease. We need to stabilize these plaques, because once you stabilize the plaques, you can prevent acute events from happening. And we need to find somehow a way to improve the blood flow in the ectatic segments. And unfortunately, we don't have much medication so far to work on that. We're going to talk about some maybe promising role for ACE inhibitors in this area. Management will differ from acute presentation or long-term management. If you find somebody has a pre-op evaluation, you send for CAT, you find ectasia, he does not have any acute symptoms, his management is different from somebody who presented with acute MI with thrombus formation in the ectatic segment. Aspirin is recommended in all patients. Anybody with ectasia is recommended because of the coexistence of coronary artery disease and because of the increased risk of ACS, even with isolated coronary ectasia. So everybody with coronary ectasia should get aspirin antiplatelet agent. Dual antiplatelet therapy is suggested. There is no prospective randomized studies to show that they do better than other patients, but there is evidence to show that there is increased platelet activity in patients with coronary ectasia. And because of that evidence, you can use that one as a way to justify adding a second antiplatelet therapy for somebody with coronary ectasia. We're talking on patients with no acute coronary syndrome. Just you do cath for them, you find coronary ectasia. Do you add a second antiplatelet agent or not? It's just debatable. There is no randomized trials, but we can say maybe it's a good idea, especially if we know that they have increased platelet activity in these patients. The question that comes up all the time is the use of warfarin or the NUOX, the new agents. Definitely the new agents we don't have any data on. Probably we have more experience in the use of warfarin in these patients. Again, there is no randomized trials that we have that check this question or not. And again, this depends on the risk-benefit ratio of the patients we have. My own remedy for these patients most of the time, if I find severe ectasia with reduced blood flow and the patient is not presenting with ACS, just presenting with symptoms of chest pain or pre-op evaluation or something like that, I like to use aspirin with warfarin. If they present with acute coronary syndrome, I like to use all of them, all the medications together. And again, there is no guidelines which one you follow for these patients. Okay. Other long-term management, statin therapy is a cornerstone. May be useful in affecting the disease progression. There are studies showing that it may delay the progression of the ectasia in these patients by inhibiting the elevated MMP3 levels in these patients, as well as we are treating the associated coronary heart disease, which is very common association with coronary ectasia. So far, we said aspirin is a cornerstone, a statin is a cornerstone in these patients. ACE inhibitors may be useful in slowing the progression of disease. We don't have yet strong data on that, but there is association reports here about the association between ACE, angiotensin-converting enzyme gene polymorphism, and coronary ectasia, and there may be a role for ACE inhibitors in preventing the progression of ectasia in these patients. Maybe similar to the data we have in coronary and aortic ectasia, aortic dilatation, or aortic aneurysm data, where we can use ACE inhibitors in those patients. Other long-term management plan, it has been recommended, and this is an expert opinion on this area. I don't think we have data on this patient, to avoid vasodilators such as nitrates and maybe calcium channel blockers. Again, we don't have strong data on this, but I would highly recommend not to use nitrates in these patients because the slow flow we have in the ectatic segments, and we add nitrates, we're going to dilate even more, and we can even may have more sluggish flow in these patients, and that can lead to angina, precipitation of angina in these patients. This is one difference between the coronary heart disease management and ectasia management. Acute presentation is a nightmare for everybody in the room here. Have somebody with ectasia presenting with acute coronary syndrome, it is a nightmare. Again, dual antiplatelet therapy is highly recommended, and this is must be done for everybody with acute coronary syndrome, regardless of ectasia or not. So we usually go with aspirin plus one of the new P2Y2 inhibitors, clopidogrel or ticagrelor or prasugrel. We load them all early on. We should start anticoagulation, heparin or low molecular weight heparin. We in the cath lab like to use heparin more than low molecular weight heparin. Again, if you have somebody on the floor who's going to wait for the weekend, maybe low molecular weight heparin can be an option. But if you're planning to take them to the cath lab and work on them, I would recommend we go with heparin rather than the other one. Once we start anticoagulation, we don't know they have ectasia or not. We take them to the cath lab, and in the cath lab we get surprised with the amount of thrombus burden they have. And in that case, we suggest we use IV intravenous drip of 2B3 inhibitors for a period of time, anywhere between 24 to 48 hours. Mechanical thrombectomy is an option. There are case reports about using IC, intracoronary thrombolytics, in these patients. Again, there is no rule. The few cases I've seen in my training that they used that really didn't work. But again, there is no definitive guidelines on that. Do you use it or not? I think it depends on the case. It depends what other options you have. And then the long-term management in these patients, warfarin or one of the newer agents. Again, there is very few data on this one, but probably a little bit more experience with warfarin on these patients. PCI. We do PCI for the coexisting obstructive coronary artery disease in these patients, and we're going to have an example, and that's, I think Dr. Mahmoud took another example for that. For the aneurysm, coronary artery aneurysm, we can use PCI with the exclusion of the aneurysm with embolization, coil embolization. And again, you're going to have somebody with you to help you with the that case. And this should be individualized. Most of the times with these patients, we send them for surgery, and we have a case we're going to present now and ask the surgeon what they think. And nowadays, we do have the option of using the stent-Ts, the exposition stent, which is a self-opposing expandable stent, and that can expand up to 6 millimeters. The question, if you have somebody more than 6 millimeters, what do you do with those? We're going to go back to our, this is a patient that we had. He presented with non-ST elevation MI, and he's a smoker. He's like in his 56, a smoker. Presented with non-ST elevation MI. He smokes like 4 or 5 packs a day. I don't know how he can do that. As we can see, this is a 2 millimeter catheter, the 6 French system we have. This is about 5, maybe a little more than 5 millimeter vessel there. So we decided to put for him the exposition stent T, 3.5, which you can push up to 5.5 or more. And the good thing about it is it's self-expanding. So after a while, it keeps expanding till it reaches the size of the vessel. And surgery is suggested in patients with symptoms, but not suitable for PCI. Maybe also considered in patients with high-risk aneurysms, risk of rupture or compression in adjacent structures. And surgeons will do either excision or ligation for these aneurysms or ectasia with bypass graft. And there are data to suggest good outcome for these patients. So we'll ask our surgeons here. We have a patient here. As you can see, this patient is 72-year-old female, diabetic, hypertensive with unstable angina. As we all see, there is a large aneurysm in the left circumflex vessel associated with coronary artery disease. There's also osteal LAD disease with significant ectasia in the proximal segments. And we cath this patient in Jama, I think before a year. She went for surgery and she's doing well. سؤال للرائد رائد الجراحة. What do you guys do for these patients in the OR? Do you ligate? Do you excise? Bypass? I mean, what procedure do you do for them? I asked our surgeons who couldn't come in today, and what they did what they call me stitches from side to side, like 4 stitches. I don't know. It is stitches and to shrink the size of it, and then bypass distal. So this is the size. I don't see. I think there is enough lumen in the main vessel. It's not really significantly diseased there. The upper branch is probably significantly stenosed, but the lower one is not. So okay, let's move on. This is the same for all ectasia cases. There's always like a lot of discussion there. Let's go back to the patient we showed first. As we can see here, there is a significant. As we can see, there is a significant thrombus in a very ectatic vessel. We do see the distal vessel, but the flow is reduced. But the thrombus burden is very large. It's a huge thrombus in a huge vessel, and I estimate the size for this vessel is about 8 to 10 millimeters in size. So, the question is what to do, what anticoagulation protocol to do for this patient, and I get shown on the slide. We give the patient heparin bolus. Unfortunately, we don't have a way to measure ACT in our patients, so we always bolus them here about 10,000 units. We aspirin load and ticagrelor load. We have been switching most of our acute coronary syndrome patients in the university hospital to ticagrelor nowadays. We load them with 180 milligrams especially a patient like this one. And I decided to give him intracoronary tiotropiban, 2B3 inhibitors, double bolus in the cath lab. Anybody will do anything different? Huh?
As you said, there's no agreement about it, but like this one, we have big thrombus burden. Maybe it is very attractive to debulk this thrombus. At the same time.
Medication-wise, will you do anything different?
Medication. I'm going to answer this. Debulking or decreasing the volume burden. This is good to get better flow. But at the same time, you may move this thrombus as thrombi downstairs, and you may cause decreasing the flow. So even putting wire there should be very cautious. If I consider putting wire there, definitely after the wire, I will go with overwire balloon or aspiration catheter, and I'll inject the tiotropiban or the antiplatelets or the heparin, whatever, downstairs after the clot, distal in the vessel. So this will be as a mattress.
But you need the medicine to work upstream also, right? Because the thrombus is upstream, not downstream.
This is because after that I will start debulking. When you start debulking and you give systemic definitely, but because of this microthrombi that you will do, you will move, and you with the interventions, you don't want it to stuck downstairs and cause for you flow. And this is worse actually.
This is a nightmare. This is a nightmare.
No flow is
yeah. So I mean, we use tiotropiban as IC or intracoronary, although the classical agent to use is apixaban, which we don't have. Apixaban is the one which is much more effective agent to use in these patients, which is not available for us. And so we decided in this patient, based on the thrombus burden we see, is to give him the boluses of everything we have here. And I gave him double bolus of tiotropiban in the cath lab. And then we did for him a thrombectomy, as Dr. Ra'ed suggested. So we did thrombectomy, and as you can see, we extracted multiple clots. We have like 2 or 3 big clots here, There's a bunch of big clots here. So we were able to extract a lot of clots in this patient, and this is his angiogram after thrombectomy.
What did you use for thrombectomy? Which device?
We have the export.
Which is really doesn't work in big clots. You need the angiojet. This is the only one that takes big clots, which is the peripheral one.
Yeah, the angiojet is not available. I'm not sure إذا في حدا في الأردن عنده angiojet ولا لا. يعني ما فيش angiojet. We only have mechanical thrombectomy. We don't have the angiojet to use for these patients. موجود؟ بأي مستشفى؟ الشركة.
Question. So what's your backup plan if you while you're doing thrombectomy and you have shortening of the line all the way down, the patient's having cardiogenic shock?
That's a good question, يعني. This is a very difficult situation, right? I mean, just like, I don't know, the surgeons are available, but are you going to send somebody to have a bypass surgery only for an RCA?
I mean, definitely. I mean, if somebody called me for this, I won't take him surgery right away because even if you bypass it, you already have shortening of life.
Yeah, that's true.
My
Yeah.
point is that you guys have any left ventricular assist devices or something to support.
Oh no, we don't have Impala. We don't have ECMO. I mean, we're trying to get ECMO JAMA. We don't have ECMO either.
Because actually, that would be the ideal. Sometimes you want to do the minimum for those patients, stabilize them, then decide to bring them back. Even if you want to do thrombectomy once they are more stable, it might be much more easy.
Yeah, that's true. Yeah. The only thing we have right now is an intra-aortic balloon pump that we use if we need to. So at this point, after we did thrombectomy, we give him all the medications we can give him. We decided to stop. I don't think it looks any better with thrombectomy because I think the clots he has is much more than what we can extract with the device we have. It was, I think, a Thursday. We took him off the table. His vital signs were stable. His chest pain was controlled, was not completely gone. We kept him on tirofiban over the weekend. And we brought him back after the weekend for repeat cath. And over the weekend, he didn't have any major events. If he had a major event, I mean, we would be really stuck with this patient. So I don't know what to do for him.
Excuse me.
Yes.
What about putting him just on tirofiban for 24 or 40?
This is what we did. Yeah, we did.
Since he's stable.
Yes.
And then go afterwards to do thrombectomy.
Yes. When somebody presents with acute MI, there's some ST elevation, chest pain ongoing. I think you give it. I mean, at least for me, you give a trial of thrombectomy. See if you, because some patients they respond, and some they don't respond. And we are, as an interventional cardiologist, and unfortunately, it's very hard for us to stop. We may not start, but once we start, it is very hard to stop, and you get stuck with that. At this point, we decided to stop, as we said. We decided to stop, and because this is the flow we got after thrombectomy, and we really get a lot of clots out of this patient, but it didn't work. So this is the image after thrombectomy, and after we gave him all the cocktail of the medications we mentioned before.
No, another question.
Yes.
What about giving him intracoronary thrombolytic?
That's a good question.
Especially if he came very early.
That's a good question. That's
give him thrombolytics, maintain him afterwards on quadruple anticoagulation, and afterwards go for thrombectomy.
Who will give this patient thrombolytics? And IC, intracoronary. Yes, Muhammad.
He will develop severe bleeding.
Severe bleeding.
Thrombolytic, agrostat, bleeding 100.
Agrostat و double bolus Brilinta. So Muhammad will not give thrombolytics.
I will not. We were part of trials on intracoronary thrombolytics and for vein grafts and for coronaries. Unfortunately, they look good on paper. They are bad.
They're bad. My little experience with that from my training, the old patients got IC thrombolytics did not do well. I mean, we didn't really. The problem with this patient has symptoms for 3 days. So I think the clot he has is very well organized. It's a red thrombus. It's very hard to extract. It's very hard to treat. So we decided at this point is to just stop, which is a very hard decision to do. And so we stopped and we decided to take him off the table. We put him, as I said, his chest pain was controlled, like 3 out of 10 or so. We put him on IV drip of tirofiban over the weekend, and we decided to watch him over the weekend and bring him back to the cath lab on Sunday to reassess. Everybody will take him back to the cath lab or not? So, Ra'ad, if you take him to the cath lab and you find that he has still disease, what are you going to do?
I would just reiterate what our friend said. If it was up to me from the start, I wouldn't have touched him. I would try your cocktail and then looked at him again, because this is a monster. The minute the wire is in, you are very lucky. The whole thing might clot, and the clot will go proximal to the aorta, and then it is a big trouble. So if I did what you have done, and I re-looked at him a few days later, most likely you will get a better flow. The clot may be disintegrated a little, but there will be lots of residual disease, and this is also another hassle for you. What are you going to do?
That's true.
This vessel will not accept peripheral stents.
Or carotid stent or some
It's
form.
a peripheral stent.
Yeah.
So whether it is a carotid, whether it is a lower limb, it is a hassle. Good luck.
And the takeoff with the RC is very hard.
It's a crook shipper.
Yeah, it's a very hard takeoff, so it's going to be very hard to get any tools to go down there.
You
Yeah.
can go with a daughter
Yeah.
catheter so that you can get above and beyond that tip.
تفضل. CT angio يوم الأحد تعمل له.
As a problem.
Is there
والله يعني بين الانترفنشن كارديولوجيست تحكي الحكي هذا صعب شوي يعني.
Is there any problem if we just leave it?
Leave him doing nothing. Medical therapy.
No repeater. If the patient does not develop more symptoms, no ECG changes, just leave the patient in
Okay.
peace.
I think that's not a bad idea. It's not a bad idea. Yeah.
You have to check the thrombus.
Muhammad will go back.
What you will do
Okay. Well, his symptoms, as we said, 3 days. His chest pain was stuttering. There was not really significant, but he has some form of chest pain. Looking back to the cath lab, and this is his angiogram after 2B3 inhibitors. And I think the plan was to leave him alone. I mean, we do see the distal flow, TIMI3 flow in these patients. Still, there's a thrombus. It's much less thrombus than before. Actually, we kept him over the weekend on heparin anticoagulation with the 2B3 inhibitor, in addition to aspirin and Brilinta. And the plan was, if it looks as good as it is right now, just to leave it alone.
But this time you did it from the top of all of these anticoagulation.
Yes. As I said, it was my friend, my partner was I was off, but this was the plan on this patient. Okay, so let's discuss. What? This is going to be my next slide. Let's see what we got to do now. So we discharged him home on aspirin and ticagrelor and warfarin. We decided to put him on warfarin. 2 weeks and 3 months follow-up, he was doing well with no angina. Unfortunately, he continues to smoke. 6 months later, he comes back to the ER with chest pain 3 days after stopping his warfarin. مش حنحكي مين وقف الورفرين بس يعني for some reason his warfarin was stopped because there were no indication on paper for warfarin. I mean, he has no AFib, no nothing. So somebody decided to stop his warfarin, and 3 days later he comes into the ER with warfarin. And his troponin was borderline elevated, was not really very high. His symptoms, again, he comes over the weekend. We put him on anticoagulation. His symptoms resolved with anticoagulation. Ra'ed, will you take him back to the cath lab?
No, absolutely not. If I'm going to take him to the cath lab, there must be a plan, a clear plan, that the previous pictures will appear again, and what I should do be very clear. I wouldn't do it just to look at the artery again and see 95% with
thrombus or something. Anybody will cath him again? What about CT angio?
I would have cut him maybe 1 month or 3 months.
After,
Post the event.
with no symptoms?
Even with no symptoms.
No symptoms.
See how
My problem with doing that for him is that if I see the same thing, I don't know what to do with it. Because I don't have a stent that I can put there, and I don't see an indication to send him for surgery only for RCA and only for PDA, PLA bypass to see what's going on. Okay. Actually, at this point, I decided not to cath him. I mean, I just decided to treat him. Because he said once we put him back on heparin with anticoagulation, his troponin was very subtle, was borderline, and nothing significant. His symptoms improved, and I told him, never ever stop your warfarin unless you ask me to do that. I'm not sure. Will somebody put him on one of the new agents, like Xarelto or dabigatran or?
There is no evidence.
No data.
No data.
No data for warfarin either.
Yeah, but data has experience. People have used it before. Yeah.
There's no data. It's
But
an
that's the
experience.
thing. If you use Xarelto, at least you will avoid somebody stopping it.
Okay.
Because warfarin, that's people will buy warfarin. We have the same problem. So if you have a primary care physician, he must take you on board. So if you are on Xarelto,
He was aspirin, Brilinta, ticagrelor, and somebody stopped his warfarin. This gives you an idea that antiplatelet alone is not enough in these patients. You need a form of anticoagulation.
association.
Yeah,
of
you
antiplatelet and warfarin, you have more than 1% mortality per year because of bleeding problems. And I would just keep warfarin and one of the
Antiplatelets.
One of the antiplatelets.
after 1 month of the event.
That's a good thing. But I mean, the guidelines for anybody with ACS is to get dual antiplatelet therapy for at least 1 year, so, right? DAPT. You need to give DAPT for at least 1 year for anybody with acute coronary syndrome. After a year, will you stop one of them or not? I mean, my thing on this patient, he's not having any bleeding issues. And he has symptoms that are doing much better. And the other thing, my issue with warfarin in Jordan, to be honest, is that we don't have very good follow-up on patients, and we don't have really assurance that their INR is therapeutic. And this is why with warfarin is an issue to stop a second antiplatelet agent. This is why I probably would say if he can afford it, is to put him on one of the newer agents. We don't have to worry about the INR level, taking it or not taking it. And in that case, I probably put him on Xarelto with aspirin or Xarelto with Plavix, with one of them. But with warfarin alone, with the issues with INR, as anybody practicing in Jordan, it's a problem. The INR goes all over the place, up and down, and we don't have a good follow-up monitoring for these patients. So for such a patient, if it's warfarin, I'll leave him in double antiplatelet therapy. If it's one of the newer agents, I may stop, maybe aspirin, keep him on the Plavix and one of the newer agents.
With the target INR treatment.
We don't have data, but all we know is 2 to 3.
Those were the low.
2 to 3, yeah.
But this patient will come back a third time.
Yes, he will.
What?
Yes,
He will with an
he
MI.
will come back a third time, but I think that the third time he will come back. If he's alive, you have to repeat the angiogram. And at that time, I think that we will consider surgery because this artery is major, dominant, huge. He has a very long PL and PDA, and why not surgery for one signal vessel? Why not if it's a dominant and he's 50 years old?
Okay, that's a good question. رائد شو رأيك جراح؟
I kind of agree on that. You know, it all depends on the patient. If the patient is
So this
young-
is his, how big is his RCA? Where is it? This is how big is his
Yeah,
RCA?
it's a big one. I mean, there is nothing wrong about taking a patient for bypass surgery for single visit. We've done it also.
Okay.
Actually, I personally do it with the robots with minimal incisions, so you don't crack the chest. But I know it's not available here. But still, even if you need it, if he's a young guy, 50 years old, and he's still a healthy guy, and he have recurrent chest pain that is interfering with his life, or he's coming with MI, and the only option for this is to take him to bypass.
So if you do that for him, would you ligate his parent vessel?
Well, in this situation, I won't ligate it, but I will do. I mean, because what will happen once you do the bypass and this will shut down. Now the other option, which is I don't know if it's available here, is like sometimes what we do bypass, and I bring the radiology or the cardiology to do coiling of the
From above.
From above. So
I
you have
see.
a graft and they coil it, so they shut it down for you. Because in certain areas, like for example, I mean this you could dissect there and do ligated it, but in the left side it would be really difficult to go into that side. And
I
ligate
see.
it.
Especially if you're going to do minimally
So
invasive.
that's what we call it hybrid approach,
I
where
see.
you have the cardiology or the interventional radiology coil it for you, and you do the bypass distal.
For me, as long as he's asymptomatic and doing well on his medicine, I will not send him for surgery. I mean, it just is
There is always nothing wrong about medical management.
exactly, yes. Okay, so this is about our patients. So, okay. So, in conclusion, coronary ectasia and coronary aneurysm is an infrequent finding. We said it's about 1 to 4% in angiography. Patients usually present with angina or MI, and when they present with myocardial infarction, it's a nightmare. There are no formal recommendations based on clinical trials. It's all based on experience and individual experience. Treatment should be individualized based on clinical presentation, ectasia, aneurysm size, and thrombus burden. And for stable patients who we discover that they have ectasia or aneurysm with no symptoms, we should put them on aspirin plus P2Y2 inhibitor or warfarin or one of the NUAC agents. These patients, I usually don't put them on triple treatment. I choose one and the other one, aspirin plus warfarin, Plavix plus warfarin, one of the other, plus NUACs. We have few patients that we started on NUACs for like aspirin and NUACs or clopidogrel and NUACs. Definitely they need to be a statin, and there maybe is a room to put them on ACE inhibitors in theory that can prevent the progression of ectasia in these patients. And if they present with the ACS, as my patient we discussed, it's a nightmare. They all need a dual antiplatelet therapy. They need a form of anticoagulation acutely with heparin or low-mercury heparin. And when they go home, they need to have some form of anticoagulation. Thrombectomy can be attempted, and our patient did not make a huge difference. I've seen it working in some patients, but it depends on the size of the ectasia and the burden of the thrombus. Maybe thrombolytics, although this is only case reports. All the cases I've seen did not really do well. PTCA, sometimes if the aneurysm size is reasonable, up to 6 millimeters, we can use one of these newer stents we have called stent Ts. And definitely we can always fall back on our colleagues in surgery, especially with aneurysms more than ectasia in these patients. Thank you.